Sir, thank you very much, sir, for your kind words. I am not deserving to the description given, sir. It is only your love and affection from the time to time we are receiving from you in organizing conferences and all those things, sir. And coming to my talk, at the outset, I thank organizers, particularly Narsimlu sir, Muruganathan sir, Manjula madam, and all other dignitaries on the dais as a faculty and colleague faculty persons and audiences. So very good morning. And we are talking on the topic that are we missing the typhus? The question has come and I need to answer. The precise answer is we are missing, yes, because it appears in the many forms: epidemic form, endemic form, classic typhus, scrub typhus, and many a times it is misdiagnosed as typhoid, particularly in tropical countries. It is overlooked in many of the acute febrile illnesses because symptoms and signs including stupor, rash, hepatosplenomegaly, thrombocytopenia, shock capillary leak syndrome, multiple organ failures, all are non-specific, and we have a big differentials list. So common among the differential diagnosis is the dengue, malaria, typhoid, brucellosis. But one other important thing is a typhus can be co-infection with the dengue, malaria, typhoid, everything too. And this painless papule, which may be pathognomonic, called as Ishkar, or subconjunctival hemorrhage in the course of acute febrile illness, could be pathognomonic, and Wheel-Felix test may support the diagnosis. All are again not confirmatory. But this typhus needs a confirmation because treatment is different and treatment is available too. Cheapest treatment, and it is available, and it will be preventing from the fatality from 100%. If untreated, mortality will be somewhere around 13% to 40% maximum. Even in this modern area, because of all the said reasons why we are missing and neglecting, misdiagnosing, overdiagnosing, overlooking, because we are not adopting the oldest principles in this modern era, that is high index of clinical suspicious and empirical treatment as far as possible are the only mantras. So hence the talk summary is don't give any chance to miss the typhus. So with this brief introduction, I'll go into the history. So the typhus means it's a confused state. So any confusional state holds good for the diagnosis of typhus. It is a febrile illness, it is exanthematous illness, and usually associated with the nervous system, which is described by the lipidemian. So it is a classical epidemic typhus versus plague versus measles versus smallpox. So this is the big differential in the 430 BC. So it is a disease of war. It is 6 times more common in the wars. So particularly all the examples are there: 1492 in the Civil War of Grenada, Seagrave warfare in the French, and during the 14th century, 5 epidemics are there in the UK. And so in the 1546, it is differentiated plague from typhus. So since there, it is a contagious disease. So during the 1820, there is a 40-fold increase in these typhus incidents because of many that scrub typhus variety, which is spreading from mite to arthropod to human beings. So there is a Charles Nicolay who discovered the pediculus corporis, which is commonly called as body louse, is a vector for this epidemic typhus. And rickets, so who described the organism in the blood and body fluids of feces of the body lice. And this Provacek died, Provacek and as well as Rickards died from the same disease during their research efforts. So that is the reason why the Provacaki and Rickettsia are the names retained. So during the Second World War, latest scrub typhus is the most common, and murine or endemic typhus is also very much there. So major impact of this scrub typhus is it is impacted a medical research causing so much of improvements in the diagnostic, prevention, epidemiology, clinical management, and transmission. So much of history is there. So there is a correlation. So to prevent the outbreaks by burning the cloths, changing the bedding and all. So this holds good for till today. So it is very effective in reducing the mortality. And with this, there is a promotion of the epidemic, the understanding of the epidemics and contagious notion has started. So in the 19th century, this illness is subdivided into typhus like typhoid, and relapsing fevers. Since then, clinical syndromes have been made very important, like exanthematous fevers and abdominal or enteric fevers and recurrent fevers. So this is the how it is divided, the so-called typhus, typhoid, and relapsing fevers. And rickettsial diseases, scrub typhus epidemics, many things are there. Bill Jenser is there. I will touch upon one by one. Rickettsia are small gram-negative obligate intracellular parasites, and the vectors being arthropods like lice, fleas, ticks, and mites, and humans being infected. When infected in the human beings, it grows in the vascular endothelium and reticuloendothelial cells. So it is the epithelium of the vector to the endothelium of the human being. So since that it is endothelium, so it will cause the vasculitis, and the vessels are affected in the multi-organs. So the scrub typhus, the chigger-bone typhus, it is called Tsutsugamushi fever, it is called, and caused by the Orientia tsutsugamushi, and spread through the thrombiculoid, that is called the larva-laying mites, that is chiggers. So rodents are also infected, but humans are the accidental host in this infection. So first described in the Japan, that is the reason why Tsutsugamushi is the Japanese word, meaning that it is a dangerous mite. And scrub typhus is very common in India. So because it scrub is a term used for the different types of vegetation, tall growing coarse grass. So it is common in the forest, gardens, beaches, paddy fields also. So this is the Tsutsugamushi triangle from the Middle East to Far East and most of the Southeast Asian region. And India is also one of the affected country for the scrub typhus. So it is underdiagnosed and underreported because the 1 billion people are at risk for the year, and 1 million cases are reported annually, and the case fatality rate in untreated cases is from 1 to 60%. So it all depends upon the type of area where it is reported, type of strain, and the previous exposure of the this one, and it is also correlated with the age of the person. So from India, specific data is not available, but still it is reported from the Rajasthan and Vellore and sub-Himalayan belt, particularly Jammu and Kashmir up to the Nagaland, it is seen. And scrub typhus in India is the re-emerging infections. So like the COVID, what we have, it is a re-emerging form of influenza in a different form. Like that, you cannot take, because we are living in the modern era, because lot of advanced antibiotics are there. So typhus can't do anything. No, it is highly fatal if you are undiagnosed, started treatment in the time. So there is also resurgence because from the World War II to a latest war in 1965 Indo-Pak War. And scrub typhus outbreaks are reported in the Himachal Pradesh, Sikkim and Darjeeling in 2004 and 2007, and sporadic incidences are seen across all across the country. It is associated with the terrain type, and many cases are within, to say the outbreak. So the terrain is important, number of cases in a certain focus is important, and number of people infected simultaneously following the exposure is important, and absence of history of the bites. History of the bites will, for epidemic or endemic typhus, for scrub typhus, there is nothing like a noticeable bite of the mite. So there is a period of epidemic influenced by the activities of infected mite. So usually it is a seasonal, a rainy season, particularly in South India, it may be the winter. So the areas affected are the forests and river banks and grassy regions. So coming to the agent, it is Orientia tsutsugamushi, reservoir is the chigger mites, and vector is a very small which inhabits in soil particularly where the micro ecosystem is favorable. So either in the forest vegetation or secondary vegetation after clearance of the forest areas and the grasses and herbs. So here, if any mice is there, mites are there. So particularly Leptotrombidium delineans, which is a vector for scrub typhus. So usually this will be by the mite larvae called as chiggers. So mite feeds their bloody meal from during the life cycle, but adult mites do not feed on the man. So when they die, so these infective agents will be present in the feces. So usually by rubbing, because of the scratchy, itchy area, so that fecal particles which contains the these Orientialis, so which will enter into the circulation and cause. So the normally larva feeds on small mammals. So the enlarged larva and adults, even though they will not bite or cause enter responsible, but humans are the accidental host in this entire life cycle of infection. So risk factors for the human infection, it is sometimes occupational also, particularly rural settings, but in urbans are also there is outbreaks because of the urbanization of the rural areas. So habitats are, I already told you, sandy beaches, mountain deserts, equatorial rainy forest. Incubation period is 5 to 20 days, but usually 10 days time after the initial bite. So coming to the signs and symptoms, chigger bite is painless. Sometimes there may be a localized itch because of which they may rub. So it will cause the local infection, so that there may be what is called local lymphadenopathy. So most common sites are the groins, armpits, and genitalia and neck. So usually a papule will develop and will become ulcerate, and it will heal by a block scar. It will mimic like a cigar mark. So there will be a sudden chills and high-grade fever, headache, photophobia, myalgia, apathy, swelling of the lymph nodes. And 1 week after that initial illness of acute febrile illness, so there is a maculopapular rash, so which is on the trunk, and later on will go to the limbs, but always palms and soles are not affected. So complicated include pneumonia and meningoencephalitis, myocarditis. Pneumonia sometimes in the aerosol form also, it may be inhaled. That is one reason. So coming to the diagnosis, I said because the symptoms and the signs are very, very non-specific, until unless you have a high index of suspicious, you can't diagnose. Diagnosis basically depends upon culture. So when culture requires laboratories like biosafety 3 level, so whole blood is the sample, and skin biopsy from the eschar or a rash or papule or macule which is more than 4 millimeters. So that culture is usually sensitive in acute phase before starting of the antibiotics. The second way is to diagnose the molecular, that is by PCR, to detect the rickettsial DNA. So again, whole body is the best than serum, and biopsy is the best than the skin scrapings. So this is also sensitive, more sensitive in acute phase, but it has a window of 0 to 48 hours of starting antibiotics also you can trust. But usually what is available for the diagnosis is serology. Serology is detecting the IgG and IgM antibodies. IgM is in the first week, IgG in the third week. So when IgG comes, it is a total zero conversion. So if you document 4-fold increase in the IgG titers, so within the 2 weeks of span, it is confirmatory. That means no single test, like in the case of Vidal. In this case, wheel flix is also useless if you have a single test. So in the wheel flix, there is also a cross reactivity, and false positives are positive, particularly if you are contemplating the infectious mononucleosis in some patients with HIV. So a infection with the scrub typhus will lead to the lifelong immunity. So that is the reason IgG antibiotics may be persistent throughout the life. So that the wheel flix cannot be useful if in a particular, it is not useful at least for the efficacy of treatment. So whether it is totally gone or not. So other investigations like blood picture will show the leukocytes may be increased or normal. There is a definite thrombocytopenia, again confusion with dengue and all. So liver enzymes may be raised, SGPT and SGOT, and creatinine will be raised because it may induce AKI in the part of multi-organ failure. So if you are going for the imaging, so either chest X-ray or CT scan, you may get the ground glass appearances and also some consolidative patches. So there is a big list of differential diagnosis: malaria, dengue, chikungunya, leptospirosis, relapsing fever, common typhoid fever, and any acute encephalitis syndrome, meningococcal or otherwise viral, also Japanese encephalitis and all. And for the cutaneous things, cutaneous anthrax is also in the differential diagnosis. So these are the commonest antibodies detected by the wheel Felix: OX19, OX2, and OXK. So OXK is highly suggestive of scurf typhus, and OX19 is suggestive of both epidemic and endemic. Indian tick syndrome is OX2. So all these panels can be given, and you need to interpret. So what is the type of this typhus, scurf typhus or epidemic or endemic? So the treatment is only simplified treatment, either oral or IV doxycycline, which is most commonly used, which is the drug of choice, 100 milligrams, repeated 12 hourly from 7 to 15 days. Results will be coming within the 48 hours of initiation of the treatment, but sometimes a combination therapy with the doxycycline and rifampicin, particularly in areas where the poor response to doxycycline is taken, and if the doxycycline is contraindicated or sensitive or anything, so alternatively you can go for azithromycin or chloramphenicol, either oral or parenteral. Also azithromycin 500 milligrams once in a day for 7 to 10 days, chloramphenicol 500 milligrams 6th hourly, again 7 to 10 days. So the vaccine is developed after World War II, but it is not commercially available. So prevention is the only thing at individual level. So full length clothing and walking without barefoot is abandoned, and insect repellents has to be used to avoid the insect bite, mite bite and all, particularly diethyl thalidomide. And community wise, rapid case identification by the public authorities and public education about the how to protect themselves, and rodent control, and improving the living conditions, and clearing the vegetation, and a chemical treatment for the vegetation. So these are the important. And typhus as a biological weapon also, because it is in the inhalation form also, it will cause the feces of the mite, so it will be living for few weeks also. So this will cause a bio hazard also because of this nature. So the World Health Organization, a 50 kg of aerosolized typhus in a city of 5 million would result in 3 lakh people exposed in 30 minutes, and 1 lakh 25 people will become affected with the illness, and there could be possible 8,000 deaths. So epidemic typhus is a classic typhus. It is seen in the war and famine. Coming to India, it is rare, but endemic part of epidemic typhus is Kashmir, and it is caused by Provazaki, and vector is the body loss, pediculus humanus corporis, and rickettsia multiply in the gut of the lice, which appears within the feces in 3 to 5 days. Lice may succumb infection within the 2 to 4 weeks, but they can transmit the infection after about 1 week of being infected also. So because of this wide gap, so you cannot expect a infection immediately after the lice have been bitten. So particularly in poorly maintained the beds and beddings, so these are to be taken. Again, here endemic is 5 to 15 days of incubation period. Again, there is a characteristic rash which develops on the 5th day, and on the 2nd week, particularly this patient will develop real typhus, that is stuperousness and deliriousness. So case fatality rate in the epidemic typhus is up to 40%. It increases with the age. So there may be a latent infections which may be reactivated when the immunity is down. So the recurrent typhus, otherwise called as Brill-Jenser disease, so which is maybe also seen in few of the cases. So coming to the endemic, it is a murine typhus. It's a milder than epidemic form. In India, certain packets are there from Pune, Lucknow, Mysore, Kolkata, Hyderabad, and Kashmir and Rewari. So it is caused by R. typhi and it is transmitted by rat flea. So coming to the clinical features, headache, fever will be there in 12% of cases. Rash develops in 54% of patients, and all other nausea, vomiting, diarrhea, abdominal pain are very non-specific symptoms. So here also, though it is a milder disease, case fatality rate 1%, and here this epidemic typhus is associated with respiratory failure in almost 10% of cases, and renal insufficiency and brain involvement causing coma, seizure, some polyneuropathies, acute transverse myelitis. So many neurological conditions will be seen with these typhus. So there are many spotted fever groups are there. So one is important for Indian point of view, that is tick typhus, Indian tick typhus, which is caused by R. conori. So here certain pockets, particularly reported pockets, are Allahabad, Narsapatnam, Ratlam, Secunderabad. So many are there. So the tick, which is species of Rhipicephalus sanguinaris, is the most common vector, and it is found in the dogs are also. So some species of Haemophilus hyaloma ticks may transmit the infection. So that's all about the various types of rickettsial disease. So any rickettsial disease, the treatment is same with doxycycline, azithromycin, and other things. So as I said, my take-home message, which was told in before slides, because it is question to the answer is that one. So thank you very much for giving this opportunity, and I'm ready for any questions from the audiences. Thank you very much.